And then you have zona fasciculata, the middle layer that produces cortisol, which is a glucocorticoid, and you have zona producing your androgens, okay? And then you have your medulla. So all the disorders are related to the production of all these different types of hormones. And this is just the pathway. You do not need to remember in detail this. This is just to show you how cholesterol as the precursor will end up forming your hormones, your different hormones. Your aldosterone right here. Okay, your glucocorticoid and as well as your adrenals. Okay. Now, I will go through the disorder of the adrenal glands by first talking about adrenal hyperfunction, conditions that are related to hyperfunction of the adrenal glands, Cushing, Conn, and CAH, adrenal hyperfunction, which is Addison's disease, and pheochromocytoma, which is the disorder of the adrenal medulla. Okay, disorder of the adrenal cortex, Cushing first. Okay, Cushing syndrome, as its name suggests, is named after Harvey Cushing, an American neurosurgeon. When we talk about Cushing syndrome, you hear this thousands of times in your life. It is basically a syndrome that comprises signs and symptoms from hypercortisolism, too much of cortisol production or secretion. Okay? Now, causes of Cushing syndrome, I've divided it into exogenous and endogenous causes. Basically, exogenous is something that outside your body, right? Exogenous, right? So it's something that you've taken, the patient has taken in excess, taken excessive glucocorticoids. Now, endogenous is whatever that happens within your body itself. Endogenous cause can be further divided into ACTH dependent or ACTH independent. What it means here is the production, the excessive production of cortisol is either due to an ACTH dependent cause, meaning there's increase in ACTH that stimulates the cortisol production to be increased. ACTH independent means it has nothing to do with ACTH. The ACTH production is normal, but somehow the cortisol production is increased. Okay, so this is how we divide them. And on the right here is just a diagram to show you the different etiologies from one of the textbooks. Okay, I'll go through each of the etiology. Now, Cushing disease, sometimes people write it CD for short. It's a type of Cushing syndrome that is caused by a pituitary tumor, usually an adenoma, a pituitary adenoma. Okay, it's the most common cause of endogenous Cushing syndrome, endogenous cause, accounting for about 2/3 of the cases. Incidence about 2 to 3 cases per million per year. And the peak incidence is in women between 50 to 60 years of age. These are just general demographics, okay? Pituitary tumors are usually microadenomas. When we talk about microadenomas, it means that they are less than 10 millimeters in size, and they usually do not cause any local mass effects because they are very small, only 1 cm, right? Macroadenomas can grow up to very large, and because they are large, they can cause compressing effects on the surrounding structures, all right? And because their region is this better? So the effects, okay, the mass effects on surrounding structures such as suprasellar extension and optic chiasm compression, because the pituitary gland is located at that region, okay? And usually it has abnormally high ACTH concentrations when compared to microadenomas, the smaller version. Okay, so I just want to show you, this is my own very simple diagram. You'll find nicer diagrams in the textbook, but this is what I've drawn myself. So you have, this is the normal condition, yeah? So you have the hypothalamus producing your corticotropin releasing hormone, stimulating the pituitary gland, anterior pituitary gland to stimulate your ACTH, right? ACTH production stimulates the adrenal glands to produce cortisol. Now when cortisol level is very high, it exerts a negative feedback reaction to the pituitary gland. It says, stop, I have too much cortisol, stop. So the pituitary gland will reduce the ACTH production. Stop, I have too much cortisol. So the hypothalamus will reduce its secretion of CRH. That's why the body is always in the form of equilibrium. Everything is balanced. Now, when you have a pituitary adenoma, I've drawn here something like this. It's just like a tumor in the pituitary gland, right? So your pituitary adenoma grows excessively. It just produces ACTH excessively on its own. Okay. Now, ACTH production is much increased. You see the very fat arrow over here. Adrenal gland is being stimulated and it produces high amounts of cortisol. That's why the patient will have signs and symptoms of hypercortisolism. Now, the normal negative feedback of the body, what it does, negative feedback goes up to the hypothalamus, stop producing CRH. Oh yes, CRH is less being produced, but unfortunately, we don't routinely measure CRH in the lab. Now, negative feedback goes to the pituitary gland. Stop producing ACTH. We have too much cortisol already. But what happens? The pituitary adenoma does not actually listen so much. It's a tumor. It just grows on its own and it secretes ACTH on its own without listening to the negative feedback from the body. That's why ACTH is very much increased and your cortisol is also very much increased. Okay? Now, ACTH secretion in Cushing's disease, it has increased amplitude, and duration, meaning the production, the amplitude is much increased and the duration is also much prolonged as compared to normal people. Okay? It has lost its normal circadian rhythm. Okay? It is not controlled by hypothalamic regulation, what I showed you just now. It's relatively resistant to negative feedback, what I've explained earlier as well. Okay? Now, the adenoma cells, however, are able to retain some negative feedback responsiveness to only high doses of glucocorticoids. High doses, yeah, I'll explain this in the subsequent slides, okay? Only high doses, normal doses it won't. Okay, so when the ACTH keeps stimulating the adrenal glands, what happened? I showed you in the previous picture, right? The adrenal glands become so hyperplastic, so big already, because it has constant stimulation by your ACTH, okay? So this leads to all these things. Now, ectopic ACTH syndrome. Ectopic meaning it's outside of where it's supposed to be, like ectopic, right? So usually the source of ectopic ACTH secreting tumor is outside of the HPA axis. Okay? Most commonly you have your SCLC, small cell lung cancer. You have neuroendocrine tumors, you have medullary thyroid tumors, and you have pheochromocytomas. Okay? So you just need to know a few examples. These are quite rare conditions, okay? But you need to know that they exist. So again, this is the normal one, right? So what happens here? The ectopic tumors, they are outside. So an example here is the neuroendocrine tumor. It produces huge amounts of ACTH, huge amounts. So the adrenal gland is also hyperplastic already. It produces huge amounts of cortisol. Negative feedback goes to the hypothalamus and pituitary. It works. Correct? It works. Your CRH and ACTH is decreased. But it does not stop this ACTH production from the neuroendocrine tumor. Okay, because this is not part of the normal HPA axis, it's outside already. So your negative feedback does not stop this one. It does stop the production of ACTH from the pituitary gland, but it does not stop this. So ACTH levels are very, very high. Cortisol levels are high as well. Okay? ACTH independent Cushing syndrome, yeah? Meaning ACTH independent, it has nothing to do with ACTH. The most common cause is adrenal adenoma. Increased cortical secretion suppresses both CRH and ACTH secretion. This leads to atrophy of the pituitary and adrenal gland. You have your adrenal adenoma over here. It produces high amount of cortisol. Nothing to do with the ACTH. The tumor here just produces cortisol. You have negative feedback, but it does not affect the production of cortisol. Okay? Sorry, I'm having a bit of URTI today. So excessive glucocorticoid therapy, meaning is your exogenous steroids that you are taking, okay? So some patients, they just take excessive glucocorticoids, okay? And this It can be due to prednisolone ingestion, oral injection, topical, etc. Most commonly, of course, is oral steroids, okay? So, this will inhibit CRH and ACTH secretion, causing bilateral adrenocortical atrophy. Okay, everything is low. Synthetic glucocorticoid, yeah? So the body thinks that, oh, you have a lot of cortisol. Okay, the body does not know it's actually synthetic. So it causes an inhibition to the CRH and ACTH. So both of these are low. Of course, the cortisol produced by the body is also low, lah. But then actually, the patient will still have signs and symptoms of hypercortisolism because the patient is taking exogenous cortisol. Okay? Okay. These are the clinical features of Cushing syndrome. Okay? So, regardless of whether it's ACTH dependent, ACTH independent, the end product is the patient has a lot of cortisol in the body, correct? So, these are the signs and symptoms of too much of cortisol, hypercortisolism in the body. What happens? You will see later on when you go to your clinical postings, when you clerk patients with Cushing syndrome, you'll see they have a very characteristic reddish face, facial plethora we call it, because there's increased blood volume fraction to the face, leading to facial plethora. Cortisol has some form of, cortisol is a glucocorticoid, right? But it has some form of mineralocorticoid activity as well. So it can actually cause water retention. In long term, it causes hypertension. Okay? Cortisol causes increased catabolism of fat and proteins. Okay? And impairs renal absorption of calcium, etc. That's why you get osteoporosis in the patients. You get thin arms and legs, muscle wasting. Okay? Because the fat and the protein has been catabolized. Over this side, long-term effects can actually cause structural and functional changes in the central nervous system. So they might have higher risk of getting depression and things like that. Okay, these are just few theories that have been published. Okay, cortisol also causes increased catabolism of proteinaceous material, which is somewhat similar to this. So you have all these kind of red purple striae on the torso. Very classical. Once you see it, you won't forget. Okay, and also you have all your collagen on the skin. It's also being impaired. So your skin becomes atrophic, very fragile, easy bruising on the limbs. If you look at the patients, poor wound healing. The wound heals very slowly because all these proteinaceous materials are being depleted. And cortisol causes upregulation of lipoprotein lipase, leading to accumulation of fatty tissues at characteristic places. They have the buffalo hump, they have the moon face, okay, and they have central truncal obesity. The fat is all in the middle, but they have very thin arms and legs. Okay, this is the very characteristic sign. Lemon on matchstick, they call it. Okay. Now, these are a few examples off the internet. I'm sure you can find more examples if you go through. Moon faces, buffalo hump, purple striae. So when you see patients like that, the first thing that you must think of is this. All right. So some of the other clinical features, they can have excess androgens causing alopecia, hirsutism, acne. Okay, they can have things like metabolic consequences. This is also very common, yeah. Patients who have Cushing's, they have abnormal glucose metabolism, they have very early onset of diabetes, hypertension, they have all this osteopenia due to the calcium absorption problem. Okay? Bitemporal hemianopia, have you heard of this before? Okay, basically when the pituitary tumor is too big, then it compresses on the optic chiasm, which is over here. Okay, it characteristically causes vision loss in this manner. So we call it bitemporal hemianopia, which can be seen in certain cases of Cushing's disease. Okay, not all, it depends on the size, what is the suprasellar extension and things like that, but this is one of the things. Okay, now we go on to investigations. Routine laboratory investigations includes what you will see is hypernatremia, hypokalemia, metabolic alkalosis. Why? Because there's mineralocorticoid effect. Okay, so there's retention of water and sodium in exchange for potassium. Metabolic alkalosis as well. Okay. Now, what are the 3 important screening tests for Cushing syndrome? You can either do a 24-hour urine cortisol excretion. You can either do an ODST. ODST stands for overnight dexamethasone suppression test, or a low-dose dexamethasone suppression test, LLDST. Or you can do a midnight salivary cortisol. This is recommended by the Endocrine Society guidelines, okay? So each of the tests has its own pros and cons. You probably don't need to know in detail at this level, but some centers, they offer certain tests over the other because of the availability, and some physicians, they order one test as compared to the others due to the patient factor as well, okay? Let me give you an example. This salivate to collect your salivary cortisol is not available in all hospitals, not available in HSAS, certainly. So if this is unavailable, the clinician is resorted to using the other two tests, correct? This is availability of tests. Number two is, for example, 24-hour urinary excretion would require a patient to bring back a 24-hour urine container and collect all the urine that is voided within 24 hours. It's actually quite cumbersome. So some clinicians do not prefer to do that as well. Okay, so a lot of factors depend, will influence on which test to be used. But either way, 3 of these tests are screening tests. You can do either one. Okay? Random or morning serum cortisol is not useful or recommended. Random one is not useful. Okay, I explained a bit about the overnight dexamethasone suppression test. As a houseman later, you might need to administer this to your patient. So basically, you give the patient 1 milligram of dexamethasone, which is a glucocorticoid, at between 10 p.m. to 12 a.m. Okay? And then you collect the patient's serum cortisol at 8 a.m. the next day. In normal subjects, once you have given the patient glucocorticoid, what will happen? The body would have a negative feedback to the hypothalamus and the pituitary gland and say, stop, don't produce so much of cortisol, right? So the next day, when you take the cortisol level of the patient, it will be suppressed. Normal patients will be suppressed less than 50 nanomoles per liter. Normal patients. However, in patients with Cushing's syndrome, they do not. The cortisol production is continuously being secreted all the time. So you won't see a suppression. So when you get this kind of finding, it means that your screening test has tell you that most likely the patient has Cushing's syndrome. Okay? So there are other tests, many other tests that you can do. You probably do not need to know so much also at your level, but you just, at least you've heard of it, that these are the other tests that can be done for you to either confirm or to localize the tumor. Okay? So I just want to bring your attention to this. Low dose and high dose dexamethasone suppression test, yeah? There are a little bit of differences, huh? Low dose dexamethasone suppression test, I did not include here in my slide, but it is different from the overnight dexamethasone suppression test, this one. This one you basically give 1 milligram midnight and you take the blood the next morning. Now this low dose dexamethasone suppression test, it is sometimes done by clinicians when they want a higher specificity of the test. Okay, it has slightly higher specificity than the overnight dexamethasone suppression test. Basically, you give 0.5 milligram of dexamethasone to the patient 6 hourly for a total of 48 hours, that is 2 days. Then only you sample the patient's cortisol after 48 hours. Okay, so there's the difference between ODST and LDST. I don't think so you need to know in detail, but just to let you know, if you read this in certain textbooks, that you know that there's a difference, okay? High dose dexamethasone suppression test is a higher dose, as its name suggests, 8 milligrams is given, okay? It is one of the tests that you can use to confirm as well. And the other test is CRH test, in which IV CRH, a synthetic one, is administered to the patient, and then you collect your ACTH and cortisol, okay? By right, no significant increase. Okay, this one basically is done to differentiate patients with ectopic or Cushing's disease. So in patients with Cushing's disease, once you have given this CRH, you would expect an ACTH increase of more than 50% and cortisol of at least 30% from baseline. Okay? But in patients with ectopic ACTH secretion, there's no. Because the ectopic tumors, they are outside of the HPA axis. They are not being disturbed or perturbed by this CRH bolus administration. Okay? So this is just a diagram to show as well. I mentioned earlier that Cushing's disease, right, can be, where was it? Where was the slide? Cushing's disease, right, it has some form of responsiveness to high doses of glucocorticoids. Okay? So it can be detected sometimes when you do the LDDST or HDDST, unlike your ectopic. Okay? Alright. Now we go on to, I have a lot of diseases to cover, so we go on to primary hyperaldosteronism. Okay. Also known as Conn syndrome, again it's named after J.W. Conn, which is an American endocrinologist. It is actually a group of disorders characterized by autonomous production of aldosterone. Just now we talked about cortisol, right? Now we move to aldosterone, okay? And it's seen in up to 10% of patients with hypertension. So sometimes you see young hypertensive patients, hypertensive patients which are not controlled with 3-4 antihypertensive medications. You need to think whether the patient actually has CONS, okay? Resistant hypertension. So what are the causes of Conn syndrome? It can be due to adrenal adenoma, which is the most common cause, okay? An adenoma is the adrenal gland. It can be due to bilateral adrenal hyperplasia at both sides of the adrenal gland, adrenal carcinoma, which is rare, and glucocorticoid remedial hyperaldosteronism, which is even rarer, okay? Just one slide on this, you do not need to know in detail. It's just a rare autosomal dominant disorder. That's all you need to know for now. Okay, so this is the pathogenesis, okay? This is your RAS pathway. You've learned about this before? Yes, huh? Okay, so basically, when you have a drop in blood pressure, okay, hypotensive, what happens is the juxtaglomerular apparatus in your kidneys, it releases renin, correct? The renin here. The renin converts your angiotensinogen to angiotensin 1, correct? The angiotensin 1 is then being converted to angiotensin 2 with the aid of ACE, which is angiotensin converting enzyme from your lungs. Now this angiotensin 2 will exert few effects. First of all, it secretes aldosterone. This aldosterone also acts on the kidney to retain water, retain salt, to maintain the blood pressure, to bring up the blood pressure, to maintain the effective arterial blood volume. And also it causes vasoconstriction. All of these, the aim is to maintain the blood pressure, okay? Now, this is the condition when you have an adrenal adenoma, okay? So this is the normal condition, right? Like what I explained just now. So renin angiotensin aldosterone pathway, the adrenal adenoma just produces aldosterone non-stop, uncontrolled production. There's a negative feedback to the kidneys, the juxtaglomerular cells of the kidneys. So the renin production is reduced. It listens, okay, it reduces. Everything reduced. Angiotensin 2 also reduced. But this adrenal adenoma, this tumor does not listen. It does not care what the people above tells it. It just produces aldosterone. So what is the importance of this? When you do a test called the aldosterone-renin ratio, whereby you measure the patient's aldosterone level and renin level, in normal people you have a normal ratio. In patients with this disease, the aldosterone will be very high, the renin will be very low, correct? So the ARR will be very high. The aldosterone to renin ratio will be very high in patients with this disease. Okay? Okay, again, what are the clinical features? Basically, because it's a mineralocorticoid excess, so you get hypertension, the main thing, and the effects of hypertension, okay? This might lead to cardiac failure, hypertensive encephalopathy, stroke, renal insufficiency, blah, blah, blah. Sometimes the patient's first presentation to you is a stroke. When you investigate backwards, then only you know the patient has CON. Okay? Other conditions, these are non-specific symptoms that might be related to hypokalemia in this case. Okay? So what are the routine laboratory investigations? Again, this is a mineralocorticoid excess. So you have salt retention, hypernatremia, potassium is being excreted in excess, so hypokalemia. All the symptoms I mentioned earlier here muscle weakness, paresthesia, muscle cramps, they are all related to hypokalemia here. Okay? The patient might have metabolic alkalosis as well. And this is what I mentioned just now, the aldosterone-renin ratio. It is greatly elevated in patients with cons. Understand? Okay? Because the aldosterone is high and the renin is very little in production. However, when you want to check for aldosterone and renin in a patient, be sure that the patient does not take all these drugs when you sample the patient's blood, because some of these drugs can actually affect the ratio. Some will cause the ratio to be high, some will cause the ratio to be low. So you want to stop certain drugs that can affect the ARR before you sample the patient's blood. Okay? Confirmatory diagnostic test is saline suppression test, and you also can do other tests to confirm the location of the tumor, CT scan, adrenal venous sampling, and genetic testing if you're suspecting the glucocorticoid remediable cause. Okay? Now, saline suppression test, you just need to know, no need to know so much in detail. Basically, you put a patient either in seated or recumbent position. You give the patient IV normal saline, okay? And then you collect the patient's blood for renin, aldosterone, and all the electrolytes after the procedure, after 4 hours, okay? So, once you give the patient saline, right, by right, the aldosterone production will be suppressed because the patient takes a lot of water already, right? So the negative feedback in the patient's body will be saying, no need to produce so much of aldosterone, correct? Now, in patients with cons, okay, the production is excessive. Regardless of you give saline or not, the patient drinks water or not, the aldosterone production is continuous because of the tumor, okay? I didn't give you the cutoff because the cutoff varies according to the units used, the analyzer, the methods, okay? So you just need to know that there is such a test, okay? Next, I move on to congenital adrenal hyperplasia. I've moved on to the next one already. Okay. What is congenital adrenal hyperplasia? It's a group of inherited metabolic disorders of adrenal steroid hormone biosynthesis, okay? It is the most common cause of adrenocortical insufficiency in newborns, okay? 21-hydroxylase deficiency is autosomal recessive, okay? And it's due to mutation in this gene, okay? If you can remember, you remember it, lah, okay? Its incidence varies from this to this, okay? Just remember 21-hydroxylase deficiency is the most common cause of CAH, the most common cause, huh? This one is could be said to be the second most common cause, 11-beta-hydroxylase mutation or deficiency. The rest, there are actually many types, but the rest are very rare. So 95% of CAH are due to this mutation. 95%. Okay? Okay. So this is the pathway of hormone synthesis that I've showed you earlier. So basically, when there's a decrease in the synthesis of the hormones, okay, cortisol deficiency, for example, it results in a compensatory rise in ACTH and also adrenal hyperplasia. So let me go to this one. Okay, 21-hydroxylase deficiency. So your cortisol is converted to pregnenolone, progesterone, 11-deoxycorticosterone, corticosterone, and then finally aldosterone, correct? So in the pathway here, each conversion requires an enzyme. So this conversion requires this enzyme. This conversion requires this enzyme, so on and so forth. Right, so in patients with 21-hydroxylase deficiency, what happens is that they have a mutation or they lack this enzyme over here. So what happens, this place is blocked, correct or not? So they don't have aldosterone, they don't have cortisol. And whatever that is produced here, it won't just stop here, right? It will definitely go to its end product. So all of these will be channeled to form androgens. So what happens to the patient? The patient has no mineralocorticoids, the patient has no glucocorticoids, but the patient has too much of androgens. Oh, what happens? Okay, next, I explained to you all of this before I tell you the signs and symptoms. The second most common accounts for 5% is your 11-beta-hydroxylase deficiency, right? So the effect of the enzyme is down here, okay? The patient cannot go down to make aldosterone. The end product is 11-deoxy only, 11-deoxycorticosterone. similar for this. Okay, so no mineralocorticoid produced, no cortisol produced. Everything that is produced up here will be converted to form androgens. That's bad, isn't it? Patient does not have any aldosterone at all, no cortisol at all. Okay? Okay, now the catch about 11 beta hydroxylase deficiency, because the block is much lower. If the block is much higher, the effects are actually more severe. If the block is much lower in the pathway, the effects are much lesser because there are other alternative pathways that sometimes can enable conversion of your precursors to your end product. So in this case, there are aldosterone synthase enzymes that can convert small amounts to aldosterone. This one is only in 11 beta hydroxylase, yeah? Just now this 21 don't have, you don't have anything to help with, Only 11 beta hydroxylase deficiency. You have aldosterone synthase enzyme, which is not shown here, that can help to convert small amounts to your final product, aldosterone. Okay. So this brings me to the clinical features here. The clinical features depend on the position of the defective enzyme. Okay, and whether the deficiency is complete. Okay. The closer the enzyme block is to the final product, the less life-threatening. Less life-threatening. Just now I told you, right? The 21 is much higher. It is actually more life-threatening. The 11 one is much lower. So it has other enzymes to help convert a little bit of the precursors to the end product. So it's less life-threatening, less life. Okay? And then you look at whether the enzyme deficiency is complete or partial. Some people, they have partial deficiency, some people have complete deficiency. Obviously, if you have complete deficiency, you don't have the enzyme at all, it's much a worst case scenario. Okay? So, what happens? What are the signs and symptoms? Mineralocorticoid deficiency. You don't have aldosterone. You can't retain salt, you can't retain water. So what? You will have hypotension, hypovolemia. It manifests as what? Dizziness, dehydration, postural hypotension, vascular instability. Because you are unable to retain water and salt in your body. Your blood pressure goes very low. Okay? Glucocorticoid deficiency. You don't have glucocorticoids already. So what happens? You don't have cortisol. You have fatigue, weakness, weight loss, failure to thrive in children. Okay? You don't have cortisol to exert its effect. Okay. Now you have too much of androgens because all of the precursors are being channeled to form the androgens, like what I said, right? So, females, they will have sexual ambiguity, female infants, okay? And if untreated, they will continue to develop masculine characteristics because they have too much of androgens already, okay? Now, rarely does CAH lead to inadequate male sexual development in the male fetus, okay? Males, however, experience early onset puberty with advanced secondary sex characteristics. Okay, so the effects of virilization is very clearly seen in female infants. Okay? So what are the clinical forms of 21-hydroxylase deficiency? Okay, you have the complete deficiency, as I've told you, which is what we call the classical CAH, and you have the partial enzyme activity, also known as the non-classic, or sometimes known as the late onset, because they present quite late in life. They are not detected early in life usually. Okay, so complete enzyme deficiency, there are also two types. The first type is the salt wasting form, whereby the enzyme activity is less than 1%, okay? It is unfortunately accounts for 70% of all classic forms. It's the majority of the classic form. You have very little to almost none aldosterone and cortisol production. It is insufficient to maintain normal homeostasis. If you do not detect early, the baby dies. Okay? Because you don't have androgen, you don't have cortisol. Cortisol stimulates your glucose metabolism in the body. The patient can get hypoglycemia as well. Okay? Things like that. In female infants, it's usually detected much earlier because of, the virilized external genitalia. But usually in all infants, within the first day of life, you noted the patient to have hypotension, poor feeding, hypoglycemia, irritability. All this tells you that this is one of the possibilities. Okay? The second form is the simple virilizing form, in which the patient has about 1 to 2% of enzyme activity, slightly better. Okay? So sometimes some of these infants, they are able to synthesize sufficient mineralocorticoids to maintain normal renal salt and water homeostasis. Okay? So they do not have mineralocorticoid deficiency because they got a little bit more enzyme to produce the aldosterone, but they do not have enough enzyme activity to maintain your cortisol production. Understand? Okay? So female infants, again, they are born with ambiguous genitalia. Now, for the partial enzyme deficiency, they retain about 20 to 60% of the enzyme activity. It's more common than the classic form. Okay? In this case, usually at birth, they have normal mineralocorticoid and normal glucocorticoid secretion. They are normal of this. Okay? And usually, they are detected at adulthood. When are they detected? When they have signs of androgen excess in females, when you see a patient, they have accelerated growth and bone maturation for their age, they have hirsutism, acne, you know all these things, premature puberty. In males, premature puberty, accelerated growth. All these are signs of androgen excess, which can only be detected when a patient has achieved adolescence. That's why some of the cases of non-classic CAH are detected only when a patient is much older. Okay, unlike the complete ones, the classical ones, they are usually diagnosed at birth. Alright? So these are just to show you the chart that people usually use to show you the different degrees of virilization according to the scale developed by Prada. Okay, so the doctors will chart the infant upon birth. What is the scale? What is the virilization scale? Okay. What are the routine investigation tests you do for patients with CAH? You would expect to see hyponatremia because the patient has no aldosterone, right? Cannot retain salt. Again, no salt retention, but no salt retention, excessive potassium retention, hyperkalemia, coupled with metabolic acidosis, and hypoglycemia because the patient has insufficient cortisol to maintain glucose homeostasis. Okay? And the classical test to confirm is 17-OHP, which is 17-alpha-hydroxyprogesterone, and also genetic testing in certain cases. Okay? Right, we move on to primary adrenal insufficiency, the hypofunction of the adrenal glands. Okay, we've mentioned the hypofunction just now. So adrenal insufficiency is a rare condition. Prevalence 100 cases per million population, 3 to 4 cases per year. If it's untreated, it is fatal. Okay, it's named after Thomas Edison. Okay, and primary adrenal insufficiency results from progressive destruction or dysfunction of the adrenal glands. It can be endogenous, it can be exogenous. So back to this HPA-axis again. Okay, destruction of the adrenal cortex, right? Adrenal cortex is destroyed. So what happens? No cortisol is being produced. So the feedback mechanism, lack of negative feedback. So there will be increased CRH and ACTH production. Okay, but cortisol levels remain very little because the adrenal glands are being destroyed. Okay, so again, you need to know what are the exogenous and the endogenous causes. Okay, so generally worldwide, infectious disease is the most common cause of primary adrenal insufficiency, but we are seeing more and more autoimmune cases, especially in the Western or the modernized part of the world, where infection is no longer a concern for them. Okay, so you just need to know what are the different causes. Okay, so what are the clinical features? Onset is usually insidious, slowly progressing over time, gradual destruction of the adrenal tissue, and the degree and severity of symptoms depend on the extent of the adrenal failure. Okay, so again, when you have mineralocorticoid deficiency, the signs and symptoms are as such. When you have lack of glucocorticoid, your cortisol, you have all these things, and you have androgen deficiency at the time because everything is low, right? Your adrenal glands are being destroyed. So you have loss of axillary pubic hair, diminished sex drive, amenorrhea in females, infertility. Okay? Excessive pituitary release of ACTH can cause hyperpigmentation of the skin. As I told you, the lack of negative feedback actually causes the ACTH production to be increased. Okay, so what are the ACTH increased signs and symptoms? You will see hyperpigmentation of the skin, the extensor surfaces, and also the buccal mucosas. Okay, the gums, the palmar creases. Okay, this is due to the excessive production of ACTH. Okay. Now, adrenal crisis is an acute presentation. It's a medical emergency. It can be precipitated by stress. Okay, so patients being treated with glucocorticoids, whether it's in a physiological dose, a small physiological dose, or a pharmacological dose, are also susceptible to adrenal failure if the dosage is not increased. The need for glucocorticoids increases in a condition of stress. Okay, so you might need to, doctors who are prescribing patients these glucocorticoids, they can't just stop the glucocorticoids suddenly as such. Or when in conditions of stress, they might need to increase the dose to prevent adrenal crises in these patients. Okay? And what investigations? Again, all the investigations that can show you adrenal insufficiency. Okay? Serum cortisol, random serum cortisol is not very useful, but some of the clinicians, they do. If the AM serum cortisol is less than 100, okay, there's a chance that the patient might have adrenal insufficiency. Okay? It is unlikely if your serum cortisol is much higher. However, you have to note that a lot of patients, they have serum cortisols in between. I'm talking about random or AM serum cortisol. Okay? There are serum cortisols in between the two extreme ranges. So what can you do? The gold standard test is what we call as ACTH stimulation test, or known as the short synectin test or tetracoseптide test. Synectin is actually synthetic ACTH. Synectin, yeah? So you basically give, first of all, you withhold steroids for the patient for 24 hours. You take the baseline bloods for the patient, and then you give synthetic ACTH, synectin. Okay? That's why it's also called the short synectin test. Okay? After you've given the patient synthetic ACTH, you collect the patient's cortisol at 30 minutes and 60 minutes. Okay? So in normal people, what happens? The plasma cortisol will be increased because you give ACTH, right? Normally, if you have normal healthy adrenal glands, the ACTH will stimulate your adrenal glands to produce cortisol, correct? So your cortisol would actually rise 200 to 550. Usually the cutoffs differ according to the analyzers, but we take a general cutoff for 550. Some sources use 500 for your level. Okay? In adrenal insufficiency, you won't get an elevation so high. Okay? So ideally, laboratory investigations should be done before starting treatment. However, if a severely ill patient is judged to have adrenal failure, treatment should not be delayed. Okay? So you can give glucocorticoid replacement, fluid replacement before you await your lab results. Okay? An ACTH stimulation test, if not possible at presentation, should be performed within 2 weeks of starting the treatment. Sometimes you can't be waiting for your lab results before you start treatment. Okay, so this is what we can do. Okay. Next, we go on to disorders of the adrenal medulla. This is the final part. Okay. The adrenal medulla produces catecholamines, but it is not essential to life. There appears to be no clinical sequelae of decreased adrenal medullary activity, but if there's hyperfunction, you get side effects as well. Okay, so I'm going to talk about pheochromocytoma. Pheochromocytoma is a tumor arising from the chromaffin cells in the adrenal medulla, the innermost part of the adrenal glands. Incidence 2 to 5 cases per million per year, between 20 to 40 years old. And okay, so these are just some of the demographic factors about pheochromocytoma. About 10% of them are malignant. Okay, about 10% of them, of the patients would have multiple tumors. Okay, and these multiple tumors may be part of MEN, if you have heard of MEN syndrome, MEN types 2A and 2B. Okay, so just want to show you this. So patients with MEN, multiple endocrine neoplasia, they have tumors at different parts of the body. So MEN type 1, they have tumors at these regions, MEN type 2, these and these. So if you notice, pheochromocytoma is present in patients with MEN type 2A and 2B. Okay, you don't need to remember this lah. Tumors here and there for your level, but you just need to know there's such thing called MEN, multiple endocrine neoplasia. And pheochromocytoma is actually one of the tumors that can arise in patients with MEN. Okay? So what are the clinical features? The clinical features are diverse and highly variable, resulting largely from hemodynamic and metabolic actions of the catecholamines. So patients typically get all these signs and symptoms: hypertension, tachycardia, headache, abdominal pain, things like that. Some of them are really non-specific. Okay? The classic triad, headache, sweating, and palpitation, is not always present. Okay? You don't always see this in everyone. Okay? Symptoms can come in attack form. You don't see it every day, all the day, 24/7. They come in attacks. Okay? And it may be precipitated by exercise, postural changes, trauma, pain, things like that, etc. Okay? So this is just to show the pathophysiology. Again, I don't think you need to memorize this for your level. Just to show you how the different types of catecholamines are being metabolized. You have noradrenaline, you have adrenaline, the two main ones. Okay? And they are being further metabolized to their end products by the different enzymes. Okay? So what are the investigations you need to do? Urine catecholamines, okay, when a patient has pheochromocytoma, the urine catecholamines will be very markedly elevated, raised. Plasma or urine metanephrines are done, that shows marked elevation also. Why? Actually, you can do either one, yeah? You do not need to do both, but certain centers only offer catecholamines, certain centers offer metanephrines. Metanephrines are better because they have higher sensitivity and specificity. Okay, imaging, CT, MRI, or radionuclide imaging to identify where's the location of the tumor, and genetic testing. Why is genetic testing important? Because, again, no need to memorize this. I just want to show you that actually pheochromocytoma has a lot of genetic implications. Okay, a lot of patients, they can have mutations, and if you screen the family members, you find out that they have a lot of similar genetic mutations depending on the site. So for example, dopaminergic secreting tumors, they had this kind of mutations, metastatic ones, this kind of mutation, just to show you. Okay? So biochemical phenotypes will serve as principal guiding feature for genetic testing in these patients. Okay, that's the end of the very, very long and boring lecture, I suppose. Any questions? Any questions you want to ask? If not, you will have your SCL tomorrow on this. Okay? If there are no questions, we shall end the day. Is Eddie here, by the way? Oh, okay. See you. Okay, thank you.